the Phallcon trial was the first randomized phase 3 trial comparing Ponatinib to imatinib in combination with those chemotherapy in patients with newly diagnosed Philadelphia positive ALL. Of course, CML transforming were excluded. It was 2-to-1 randomization. The study had induction part of 3 months, consolidation, maintenance, and then single drug till progression or death. The primary endpoint was end of induction MRD negative CR, means you have to have an MRD negativity into -4 and CR lasting for at least 1 month. This is the primary endpoint. Secondary endpoint were event-free survival. This is the key secondary endpoint, survival and safety, of course, and duration of response. Patients were well balanced between the 2 arms, median age being close to 60, with 37% above the age of 60. It's important to notice that half of the patients and more have at least one risk factor for cardiovascular event. The primary endpoint was met. In fact, there were double the rate of patients achieving MRD negativity CR in a Ponatinib arm compared to imatinib. This rate was around 35% compared to 17% with imatinib. If you consider MRD negativity alone, this rate was even better, 40% with Ponatinib compared to 20% with imatinib, which is exactly what you expect in standard of care. The benefit was seen across the board, mainly in older patients compared to younger patients, was shown at ASH as well this year. When it comes to patient disposition, where more patients staying on Ponatinib arm compared to imatinib, the reason why lack of efficacy in the imatinib arm and more patients going for transplantation. As a disposition of this patient and follow-up, we know that more patients on imatinib arm receive subsequent therapy, be it immune therapy or Ponatinib or other TKIs, and that may account for what's called crossover design. We know that MRD negativity CR on Ponatinib are more durable than imatinib, and patients on Ponatinib arm receive less subsequent therapy compared to imatinib. We know that the response were deeper on Ponatinib arm across all the time. When it comes to event-free survival, secondary endpoint defined by no CR, relapse from CR, and death. Despite the crossover design, despite the short follow-up, the EFS was trending in favor of Ponatinib. When we take into account a lack of MRD negativity CR and loss of molecular response, that is PFS was clearly in favor of Ponatinib. When it comes to survival, there was no difference. The follow-up is still short, but important to note as well that standard of care arm did perform better than expected due to the crossover design of the trial. Finally, when it comes to safety concern, there was nothing significantly bad more with Ponatinib. Of interest, the arterial occlusive events were observed at a very low rate, 2% with Ponatinib, 1% with imatinib, and there was no more discontinuation rate on the Ponatinib arm compared to imatinib. So in conclusion, what we've seen from this trial that Ponatinib is more efficacious than imatinib, double rate of MRD negative CR with a trend for better long-term outcome. However, this benefit did not come at the price of increased safety concerns. In fact, the treatment was as safe as imatinib, and therefore Ponatinib should be considered standard of care in the near future.